In the right hands, spinal anesthesia, a neuraxial anesthesia technique, can be used to effectively provide anesthetic for lower abdominal and lower extremity surgery. In this film, relevant anatomic and physiological considerations will be discussed, as well as how to prepare equipment, medication, as well as a patient for the procedure. In broad terms, spinal anesthesia entails the introduction of local anesthetic into the cerebrospinal fluid. Anatomical landmarks seen being marked on the skin now are used to guide the advancement of the spinal needle into the subarachnoid space at the level of the lumbar spine. With the aid of an inlay, some anatomical structures will now be identified. The spinal column and its relation to the bony pelvis is now shown. Take note of spinous processes of the lumbar vertebra. The manner in which the patient is seated has a bearing on the orientation of these structures, which in turn has a bearing on the success of the needle being advanced from the skin into the subarachnoid space. In flexion, the space between the spinous processes is maximized, while in extension it is minimized. For this reason, it is important that the patient be positioned optimally, lying down or seated in lumbar flexion. In this position, a schematic will be used to demonstrate the relationship between the subcutaneous tissues traversed by the spinal needle. Take note of the spinous processes of the vertebra, the supraspinous ligament, the interspinous ligament with the interspinous space, the ligamentum flavum, the dura mater and closely adherent arachnoid matter, the subarachnoid space containing CSF and into which the local anesthetic is injected, the spinal cord, and finally the posterior longitudinal ligament. For neuraxial anesthesia to be performed effectively, the relationship between palpable and not palpable structures, as well as visible and not visible structures, needs to be understood. Neuraxial anesthesia may result in the complications of high or total spinal anesthesia. The action of the injected local anesthetic on sensory, motor, and sympathetic nerves may result in bradycardia, hypertension, and rapidly ascending paralysis. Depending on the level of paralysis and affected nerves, difficulty breathing or complete respiratory depression may occur. In some instances, the level of the spinal block may even cause airway compromise and unconsciousness. Therefore, before administering a spinal anesthetic, resuscitation equipment such as a laryngoscope and resuscitation medication such as atropine should always be prepared. Failure to establish an adequate spinal block may require conversion to a general anesthetic. For this reason, medication and equipment required for a general anesthetic should be prepared beforehand. Vasoconstrictors such as ephedrine or phenylephrine are required to treat hypotension that occurs as a result of sympathetic blockade. There is significant overlap between medications used for resuscitation and those used for induction of anesthesia. For more detailed elaboration of this, refer to the course Introduction to Anesthesia, Induction. Monitoring is a key component in the provision of anesthetic care. In addition to ECG electrodes, an oxygen saturation probe and blood pressure cuff are now placed on the patient. The minimum required monitoring during a spinal anesthetic is blood pressure, ECG, and oxygen saturation. Because of potential respiratory complications, some anaesthetists monitor end-tidal CO2 routinely. In the first 5 to 15 minutes of a spinal block, monitoring is essential. In this period, each of the previously mentioned parameters should be checked every 5 minutes to ensure the patient has not developed a high or total spinal anesthetic.